2, 1.
Hello, Dr. Dominic Carreira. Thanks for this opportunity to present this topic to you. I'm in the Atlanta area with Peachtree Orthopedics. If you have any questions or want to reach me via email, those are listed here, dcarreira@gmail.com, or my cell is 954-465-9849. I'm happy to answer questions for you. So we're going to go over, essentially this topic is capsular management in hip preservation surgery, and specifically related to arthroscopy. And it's really relates to hip microinstability and then borderline dysplastic patients or low coverage patients in terms of the acetabular coverage. My disclosures are I have royalties consultant and paid speaker for ConMed. I'm also royalties consultant and paid speaker for Zimmer Biomet. One of the suture passers that I use for capsular management is a Zimmer Biomet product that will be shown later on as I go through some videos, and some of my research work is supported by Arthrex. Factors contributing to hip stability. There are numerous factors. Osseous coverage is the one that we most commonly think of and is the most crucial. Other factors include the labrum, which we know is not only a pain generator, but also a stabilizer to the hip joint. The capsule is important and is a main topic for today. Ligamentum teres has an effect in terms of stability, particularly when going into external rotation, as noted in this picture, as it becomes taut, and also with distraction type forces. The muscles and tendons are dynamic stabilizers, so they're important in terms of strength and tone. In patients who do have hip microinstability, similar to what we do in the shoulder, we try and get them stronger, and that's also a focus. Finally, femoral version, with femoral aneurysm being a factor that contributes to instability. And typically, the version is noted with physical examination, and if patients are having arthroscopic hip surgery, a CT scan also helps to further define their version. The hip capsule, what is its structure and function? Well, it's involved with proprioception and active hip stabilization, and it is a structural support, with the iliofemoral ligament of the three ligaments noted here being the most important. It's up to 1/4 of an inch thick, and it resists extension and external rotation. It's important to note that, and we protect patients after surgery from that specific position, extension and external rotation, once the capsule is closed. This is just pictures of it with the iliofemoral ligament being in this a level B type of a picture, demonstrating it draped across the front of the joint here. Factors in terms of hip instability with regard to etiology. Traumatic is one. These are high impact or high level energy injuries with the potential for frank joint dislocation. These are not common in my practice, or I think in most of ours, but in the setting of maybe a level 1 trauma center, it can happen. I was previously affiliated with a level 1 trauma center, and it was rare to see a dislocation that didn't involve a bony contribution. Atraumatic injuries, dysplasia being an important one, ligamentous laxity, typically associated with generalized hypermobility. And then it can also exist in repetitive sports, particularly where there's stretching associated with it, such as figure skating and ballet. FAI related, posterior subluxation has been described in the setting of femoroacetabular impingement. As the cam engages, the hip can subluxate posteriorly. And then iatrogenic, either a gross dislocation, an unrepaired capsulotomy, or an over-resected capsule. As we look at these, the iatrogenic is a potential cause for failed hip scopes, and is part of the focus of this talk. Atraumatic is not uncommon, meaning that That's what I probably see the most commonly, making an effort to identify it if present, particularly with regard to hypermobility, and it's more common in females. An FA-related subluxation, treating the CAM essentially treats that effectively. So microinstability, it's this circle of injury or abnormal motion that contributes to it. It is difficult to diagnose and quantify. In our multi-center study group called the Multi-Center Arthroscopy Study of the Hip, we essentially, from a data collection standpoint, identified patients as micro-unstable, although we did not use specific criteria because we felt it was so difficult to truly quantify it. It can be secondary to connective tissue disorders like Ehlers-Danlos, Marfan's, or Down syndrome, and then also contributed by muscle weakness. Some of these patients, especially if they have microinstability, if they shut down, meaning they become less active, a lot of times they won't improve, or they'll even feel worse because the muscle weakness then contributes to further instability. Also increased risk with repetitive microtrauma, particularly in dancers. A clinical examination, the Baton score is a score that we regularly take in our patients who we suspect may have microinstability. These are just the factors that we look at here. This picture shows two of the criteria, which is forward bend. It's a palm to floor with the knees straight. In this case, demonstrating hyperextension of the knees in both pictures. Hyperextension of the elbows, thumb to forearm, and fifth finger hyperextension. The other diagnostic test that can be used that I think is more helpful in the hip is this log roll test. So just externally rotating the patient. If they go well beyond 45 degrees and there's a loss of an endpoint, that's considered a positive log roll test. And you can see in this patient just lying supine, the extent of external rotation without stress, suggestive of a positive log roll test and instability. Obviously in these patients, looking at factors beyond just the soft tissues, such as the bony stability and bony alignment is important. So in terms of imaging, this osseous imaging is really based on x-rays. Additional studies can be performed, such as a CT or MRI, with the CT being the more helpful. Basic measurements that we know for dysplasia: tonus angle, lateral center edge angle. There's also a Sharp's angle noted here, and the anterior center edge angle, which is noted on a false profile view, is also helpful. Soft tissue MRI imaging can potentially show high-grade tears of the ligamentum teres. We also look for labral tearing, and then potentially capsular ligamentous deficiencies, particularly in the post-operative setting, can be looked for via arthrogram to see if there's a persistent defect in the capsule, which can be seen following hip arthroscopy. So true dysplasia is a lateral center edge angle of less than 20. Borderline is thought to be between 20 and 25 on lateral center edge angle. This is on the AP views and denoted below here. I think that this is the single most helpful test, but stability really needs to be looked at with all of these factors, including an anterior center edge angle through a false profile view. And in the setting of borderline dysplasia, arthroscopy can be considered, but plication should be associated with that in terms of the procedure to prevent and treat microinstability potentially. Capsulotomies, there's different forms that have been described. The interportal capsulotomy is the most commonly used capsulotomy type. Basically, it's connecting the two portals that are used most commonly, which are the anterior lateral portal and the mid-anterior portal, or the other one that's commonly used is a modified mid-anterior portal. And that's simply connecting the two portals that are used to enter the joint. And that connection is usually made or attempted to make at least 1 centimeter away from the labral margin so as to be able to maintain tissue for capsular closure at the end. The T-capsulotomy is also can be performed, and certain schools of training use it more. And I would say there's a trend away from it. It probably leads to better access in terms of visualization and understanding that the T portion is making a perpendicular cut from the interportal capsulotomy noted here above. Historically, the form of capsulotomy has not been reported well in studies. This review from 2017 showed that only 7% of the studies reported the technique. And so in comparing these approaches, it's difficult to understand because outcomes that have been done historically because of the lack of reporting. In the last 3 years, there's been a much greater reporting and interest in the capsule, which we'll present a little more here too. So here's a video of an interportal capsulotomy. So the labrum is on the left side of the screen here. This is capsular tissue here, and this is the femoral head. And so the capsule is cut in line with the labrum, leaving a margin there. And the two portals are interchanged in terms of visualization and connected. Sometimes the portal can be extended, in this case down the screen, which would be further posterior. And when looking from the anterolateral portal, it can be extended a little more antero-inferior to increase visualization, which can be especially helpful once the femoral osteoplasty, the CAM treatment's performed. So the management options are repair, plicate, or leave unrepaired. We will go through these, review them. So here's a closure technique using a passage device. The vicral suture in this case is passed through the leaflet that's closer to the labral margin. It's raised up into the peripheral compartment here. This bone here is the femoral head that's been resected in terms of CAM. Here is showing the closure technique, which Mark Philippon taught me when I trained with him, which is essentially like a luggage type of a suture. And it's a double strand technique in order to close it down. So after passing the suture, this luggage-like suture is then kind of shimmied down to close the capsule. And that's what it looks like at the end. This is the first double-stranded suture passed, and this is the second one with the labrum noted here. And the hip is brought into extension to ensure that that closure is maintained at the end and prior to closing the skin. You can get into situations where that help us to know that the capsule is very elastic, and that's what's shown here. So I'm using the sharpest blade that I know to be available for hip arthroscopy, a beaver blade. And instead of the knife actually cutting through the capsule, it's actually pushing it away. So this is defined as a patulous or highly elastic capsule. And this is one of the factors that helps us to understand at the time of surgery the degree of elasticity. This is an example in the bottom right where the capsule is really tough to cut. So I've got that same really sharp blade, and the toughness or the loss of elasticity of that tissue doesn't allow the blade to actually cut through it. So you get, as so many things in orthopedics, you can get a wide spectrum of disease or presentation, and this kind of illustrates the two extremes. So capsular plication is essentially, as opposed to repair, where it's just a simple closure, the plication is designed to create a volumetric reduction. This is the definition that our study group has used to publish. And the volumetric reduction is achieved by larger bites in the capsules, potentially more sutures. In my case, I use 3 sutures for closure. I'm sorry, three sutures for plication versus 1 to 2 for closure, and then also inferior shifting of the sutures. So they can be passed in a slightly oblique manner, as demonstrated here, in order to create further volumetric reduction, as shown in C. So this is what it can look like following repair versus plication, A to B, with B being the plication, as demonstrated by Jackson and AJSM. So when to plicate? Well, I think many factors need to be looked at. History. Has capsular plication been done in another joint, including the shoulder? Is there history of anterior knee or patella instability? Hyperlaxity, Baton's criteria being positive, increased femoral aneversion, any sort of soft tissue or connective problems such as Marfan's or Ehlers-Danlos. Range of motion. Supraphysiologic, is the range of motion greater than normal? So if I see 40 degrees of external rotation and 15 to 20 degrees of internal rotation, commonly in patients when examining their hip rotation at 90 degrees of flexion, these patients will have more total range of motion and a softer end feel and an easier flow through the mid-range as they're rotated. So that's also a factor that's helpful. We demonstrated in our study group that range of motion assessments are reliable when looking especially at total range of motion versus looking at just internal or external rotation. So I think we can get a sense of that as a potential contributor. Lateral center edge angle, as I've mentioned, as well as acetabular index and anterior center edge angle on the false profile view. MRI can be helpful. Capsular redundancy noted on MRI, ligamentum teres tear, thickening of the iliofemoral ligament. Also a vacuum sign or easy distractibility with joint distraction when the patient's placed into traction at the time of surgery, and then the manual probing. Also ease of entry with the cannulas or passing the needles into the joint at the time of capsule entry. That also is additional information that can help us to understand stability. Here's the plication technique. So this is actually passing through the leaflet closer to the labrum on one side. I've used a double-stranded technique here. I think a single or double strand technique is certainly reasonable. And then the suture passing device is passed along the more distal leaflet, extending down towards the femoral neck margin. Larger bite there. You can see it's even well away from the area of capsular trimming to visualize the joint. Here's a second suture passed. In the setting of plications, non-absorbable sutures are more regularly used, I think, by almost uniformly by hip arthroscopists for plications versus the use of absorbable sutures in standard repairs. And these bites can be taken in 30 to 45 degrees of flexion in order to gain and visualize as much capsule as possible. And as I mentioned earlier, then brought into extension to assess that the sutures haven't pulled out once they've been passed. So outcomes, repair versus release. This is a study by Ben Dome, 65 closures, repair or plication. versus 65 that were unrepaired. And there was significant improvement noted at 2 and 5 year follow-up with patient-reported outcomes. And there was, in the unrepaired group or the simply released group, a significant decrease in modified Harris hip and satisfaction between 2 and 5 years follow-up with an increased conversion rate to total hip arthroplasty. Here's another study published in the Journal of Hip Preservation Surgery with 245 hips, 247 with closure versus unrepaired. And as demonstrated here, with capsular closure, the numbers were higher in terms of outcome scores. Here's one where there's a complete repair of the capsule versus a partial repair in terms of the study. There was significant improvement seen at these different time frames of 6, 1 year, and 2 years, regardless of the technique used, meaning regardless of whether complete versus partial was performed. And complete repair did demonstrate superior sport-specific outcomes. The partial repair group had a higher revision rate compared to the complete repair group. Plication outcomes. So now looking specifically at plications versus repairs. Study again, these are all pretty much more recent studies showing that there was a matched control group. And in the performance of T capsulotomies, there was no significant differences noted between ligamentous laxity and normal groups when closure via plication was performed. So interestingly, in this group, there was a higher satisfaction in the lax group. I would say that hasn't been my experience or our study group's experience. We think they're equivalent, maybe a little lower in patients who have laxity in terms of outcomes. In terms of additional studies looking at risk factor analysis related to plication, this is a study that included patients who were tonus grade 1 or less, had a low to borderline dysplasia, and a minimum 2-year follow-up, and there was no significant difference found in the baseline patient-reported outcomes. Interestingly, the failure group was those that were older. They were 2.25 times more likely to fail than younger patients in this group. Another study of systematic review related to dysplasia and their outcomes. There's note made that dysplasia is defined differently across the studies, but it's clear that in dysplastic versus non-dysplastics, arthroscopy has worse outcomes in dysplasia. And in comparing dysplasia versus borderline dysplasia, there were conflicting results. So in the frankly dysplastic patient, it's clear that arthroscopy is not the appropriate treatment. Our study group in 2019 did minimum 2-year follow-ups comparing borderline dysplasia normal coverage versus over coverage, and there really wasn't any difference noted between the coverage groups in terms of ultimate outcomes when treating the pathologies as a standard of care. Dysplasia versus FAI, a study by Chris Larson looking at dysplastics versus non-dysplastics. There was lower, there were higher failure rates or lower successes in the dysplastics relative to the FAI. This highlights some of the controversy with the borderline dysplastics and looking at outcomes and in the hands of a very experienced surgeon like Dr. Larson. Thanks very much for your time. I hope this has been helpful to you. This is my email address, and as I mentioned, you can certainly call me too. It's at the beginning of the talk, and hope the remaining part of the Georgia Orthopedic Society has been fruitful for you as well. All right, have a good day. Bye-bye.